thank you everyone for joining, and thank you to our wonderful presenters there. What I'd like to do is to welcome you to the next part of the webinar, which is a panel discussion. My name's Claire Wilkim-Hastie, and I'm a Scientific Director at SCS, who are helping facilitate this webinar today. And then on the line we have Jesus Benales, John Bridgewater, Shahid Khan, Andrew Murphy, and we also have Helen Mormont with us today. What we'd kindly like you to do is submit any questions you have for the panel through the Q&A function, which should be at the bottom of your screen. And then I'll facilitate by reading out any questions that are coming through there. So I think we do have some questions already coming through. So the first one is more of a comment than a question, but for the panel to discuss. The new ICD-11 changes don't need a certified professional, which means anyone can pick up the diagnosis easily through the website and software. Do we see that as a challenge with regards to the panel? I don't know if Shahid, do you want to comment on that one?
I think that the system seems a bit easier. I mean, one won't know whether it's until people start using it widely. I still feel, I've always felt that the coding needs to be better. I think senior clinicians should have a more proactive role in the coding. I think that's when it comes to patients being discharged from hospital for whatever reason. Because if you don't accurately code all the things that have been done for that patient, all the diagnoses, firstly, it's not good for data collection. Secondly, your hospital doesn't get appropriately remunerated. And I think when it comes to the MDT, I only do an MDT. Well, I do MDT at several hospitals, but we don't have it's not routine practice for a senior member of the MDT or the MDT lead to sit with the MDT coordinator at the end and go through the coding. He or she may go through with the MDT coordinator and say, right, this is the plan. Just to recap, we've got the right plan. But in my experience, they don't sit there and say, okay, the diagnosis here was neuroendocrine tumor, code it as this, or the diagnosis was perihilar, code it as this. I'm not sure if that happens. John, I don't know if that happens at the MDTs you go to. It doesn't happen at the MDTs I've been to.
I was about to say, it doesn't happen at the moment. The closest MDTs get to that is TNM, because TNM is now mandated. And so, there's this sort of wringing of hands when they have to put down the MDT, but when they have to put down the TNM. But I think that actually the MDT is probably the only place where correct coding is ever going to happen, because as you say, once the patient is out of there, there's no process for doing this, and the people who are doing it are not, with the best will in the world, not sufficiently senior, not sufficiently able to get it absolutely right. And so I think you'll get a bit of flack from your colleagues for suggesting this, but actually, maybe we should start recording the TNM at the MDT. These discussions are very important, and actually, quite frankly, the first MDT to do it and to produce a real TNM staging for patient, a real ICD code for every single patient. I mean, that'll be quite a feather. Yeah, quite a feather in that MDT's particular.
That would indeed be excellent. I mean, at the moment we're not we don't even really get much in the way of staging, which is what we're seeing, that's not recorded. But I'm just wondering if this is something that Andy might like to comment on, because this is all happening at MDT level, isn't it, when the diagnosis is confirmed, and then it's really up to the coder or the recorder who's keeping all the notes and then coding to check the correct codes. And if I'm understanding what Claire is saying, that she's picked up from Robert Jacobs' talk, is that it should now be easier if you hear the words perihilar cholangiocarcinoma, it should be easier to track what code it is and to record it. And I'm just thinking with the COSD, and obviously I'm only talking about the UK, I'm not sure what happens elsewhere, but with COSD and so forth, if we had ICD-11, could you see that being better coded and recorded, Andy?
So thank you. So within CIRRUS-D, which is a Cancer Outcome Services dataset, for those that don't know what it is, which is the largest cancer dataset we have in the UK, records all information about the diagnosis all the way through to treatment. We have a series of fail-safes in there to try and get the best quality data coming through as we can. One of the things that we do is we work very, very closely. We've got a team of people around the country, liaison officers, and they go into hospitals and they work with MDTs. And one of the things that we recommend people to do within the MDT is to have a clinical champion. Now, that doesn't have to be the clinical lead, it doesn't have to be the consultant, it could be a junior doctor, but to have a clinical champion who can work with the MDT coordinators so that if they have any queries or they didn't understand the complex discussions that were happening after the MDT, they could sit down with them and they could go through each case, and then they could make sure that the performance status, the T&M stage, or any other clinical coding is actually entered correctly at that time.
That sounds perfect.
Can I just say that with the coding outside of cancer, the world of medicine in the NHS at least is really getting a lot more savvy, a lot smarter with the coding. So because our managers have been telling us that if we don't code for everything that, if we've had a patient in for several weeks and they've had pneumonia and MRSA or whatever, if we don't code for all of those things, then we don't get remunerated for everything that's been done. And actually hospitals are now increasingly employing doctors or paying doctors additional sessions to go through coding for their medical admissions to get the coding right. And we need to adopt that approach, I think, for cancer. I'm really interested to know in the US how the coding is done, because obviously they have a different system of billing. I would guess that they're probably better at making sure all the coding is done because of the way the insurance system works. So you need two things. You need a system, a coding system that is accurate and works, but then you also need the right people putting the right codes in.
That leads on to another question we've actually got in the chat, which is for those living in countries that have not yet planned to start ICD-11, what actions are recommended? I think this has come up a couple of times in previous webinars, actually, how to prepare for the start of ICD-11.
Well, I would have put that question to Jacob, who unfortunately hasn't been able to attend. I don't know. I mean, I've only worked in the UK setting. I mean, yes, I've been fortunate enough to travel around the world and meet wonderful colleagues from all over the world, but I don't know enough about systems in other countries to say. I don't know if Jesus, you have any comments to make. I mean, obviously you're, as chair of EMSCA, you have colleagues from all over Europe. You've done a lot of the real life clinical mapping of what's been going on. So you've probably got a lot of experience in how people record the data.
Yeah, thank you, Zahid. Yes, in the European EMSCA registry, I also saw a comment in the chat. They are asking if we see these epidemiological differences on perihilar, if we see more cases of perihilar tumors in the registry. Well, also there is a bias in the registry in terms of who include the data in the registry. We have a significant proportion of professionals, hepatologists, so they are including mostly intrahepatic cases. So most of the cases in the registry, actually I can see the data from here for 2,200 cases, more than 1,200 are intrahepatic, but still we have 600 perihilar and 400 distal. The good thing is that we have, all the patients have histological confirmation of the diagnosis, and the location of the tumor is well indicated. And what we saw from the preliminary analysis is that indeed the different subtypes have, and we confirm that they have different risk factors associated. Some risk factors are more close to extrahepatic, in this case distal, or perihilar compared to intrahepatic, and vice versa. And regarding management, they have obviously a different management, and the outcomes also are at certain level different. For example, patients under best supportive care, patients with intrahepatic cholangiocarcinoma show worse outcome compared to perihilar and distal, probably to the underlying chronic liver disease associated, no? But in terms of surgery, or in this case, palliative active treatment, there are no significant differences to the moment, according to the numbers that we have in the registry, okay? But again, I think in terms of incidence of the different subtypes, I think we need to carry out prospective analysis and try to demonstrate this.
Great.
Can I just go back on what the question Claire sort of put before we moved into that? And that's always fascinating to hear, you know, what's happening in the registries in Europe. But I think it's very difficult for people to plan to take on ICD-11, because it's not down to the individual, it's down to the health authorities in whatever country you happen to be in. And these ICD codings have been adopted, you know, in certain countries years after other countries. So and what we'd really like to see is that it you know, the global uptake of ICD-11 is much more rapid. But again, I'm going to turn to Andy, because he's you know, our person on the you know, with finger on the pulse of what happens in the choice of coding directories, etc. And so how does you know, interested medics, interested people, how do you persuade a health authority to adopt a new coding system?
So within the UK, we've got NHS Digital and NHSX, and they have already set up a small task group to look at ICD-10 versus ICD-11. But also in the mix with that as well is SNOMED CT, which is what they are at the moment. There's a huge drive towards collecting more data using SNOMED CT, which is again is a clinical terminology system. So you have got competing different systems there, and the priorities are set at a national level, as you said. And once they are set, once they're agreed and set, at that point, then we can start working with system suppliers to make sure that the system suppliers have got the necessary ability to make changes to their systems so that you can record the different staging data accurately and without too much burden. And then once you can do that, you can then start rolling it out and doing training on it. But there is a difference between ICD-10 and ICD-11. ICD-10 is very easy to understand. A lot of people are using it now for many, many years, and most of the codes they know off the top of their head without having to look up reference codes and tables. We go into a new system, people have to be retrained and will have to understand how to do that. And that will probably have to happen with an interface, as Jacob showed, whereby you can type in what you're looking for and it will come up with the code that you're going to need, but they're not going to be necessarily initially easy to remember every single cancer code that's required.
No.
I think John's got his hand raised there. Hi, John. Yeah,
no, I mean, that's the way that we would, what Andy's just described is the way that we would do it in a sort of national health system. I mean, the other way of looking at it, we have a bit of a flavor of this where I work, because we've got an American electronic patient record system, is follow the money. You do not get paid on this system. There's a bit where you say coding and then charges, and we don't go near that bit. But maybe we should use that to begin to enforce proper coding, because it's not really happening at the moment. And a bit of a stick perhaps needs to be applied. As ever, there's a delicate balance between carrot and stick, but a bit more of a stick. You don't get your department is punished unless you filled in your codes for the week. I don't know.
I remember that being quite common in general practice when I was working in the UK. And so we have another comment from a participant. Maybe John, I could put this one to you, which is, what about patients that have more than one lesion near different locations? In the respondent's experience, it's not so rare. Could they adopt a more common terminology? But I guess that comes down to speaking to someone more senior and getting the coding correct.
You have to put 2 codes. Yeah. And is that right? You just have to put 2 codes if you have 2 cancers.
Yes. So in the UK, if you've got 2 different cancers, you would have 2 completely different records created for that patient, and then each record would have its own unique codes.
I wonder if the question means, maybe the questioner is saying, what if you've got a tumor in the perihilar lesion, and not so far away you've got an intrahepatic tumor as well?
Yeah.
Are we going to assume that's a perihilar that's led to intrahepatic mets, or if you've got a tumor that's invading into the gallbladder and also breaching the liver parenchyma, is that a primary intrahepatic or is that a primary gallbladder? I think that's what the question is getting at. And it's not that rare, I would agree, and I think that's why the MDT is the place, because that's where you have all the expertise. At a proper MDT, you'll have more than one radiologist, you'll have at least a couple of surgeons, if not more. You'll have ERCPists, gastroenterologists, liver specialists, oncologists, radiation oncologists, medical oncologists, and if between them they cannot come to a conclusion, because it is very much a case-by-case thing. You have to look at the clinical features, how the patient presented, maybe, and if then that's the best chance of coming up with the most likely original site. And if then there's it's impossible to conclude, then maybe it should be called, and only then, other or indeterminate, and which there is an option for.
Multifocal, no, undetermined multifocal, probably.
So
That's I believe the question of Jorge Adeba, from Madrid. I send regards from all of us.
The only other fallback here that I've known of that is, and not very frequently, quite frankly, because normally the MDTs are pretty good at calling, is actually, you do the profiling and you find the patient has something that is generally speaking thought to be unique to the intrahepatics, and then you can be a bit more sure it's an intrahepatic. Yeah.
So great, thanks. We've had another question in. Helen, I wonder if you had some light you could shine on this, but is there a white paper or some document to help convince the US system to change sooner rather than later? From a patient advocacy position, that seems vital.
There isn't anything that I know of. I mean, we'd like the UK to change sooner rather than later. We're not able to do that either. So no, there isn't anything at the moment. All we can do is to keep stressing, that as Shahid has so eloquently, done in his talk, is to show how the coding has been misleading us, and especially never ceases to amaze me that, the clinical picture shows 50+% of cholangio diagnoses are probably perihilar, but the data show 1.2% in that work he was looking at. Huge difference. We really need to get better coding. No, if only there was, but I don't know of a white paper, no.
Thank you. Are there any other questions the panel would like to put at this point?
Well, I would like to come back on the one that Jorge put in his the question he has had about the differences. You know, how should you describe, how should you code a lesion that's occurring within these different locations? And it's a bit of a question really, apart from a comment or an answer. And that's thinking of some of the presentations that we've seen at AMMF's conference and so on from Professor Robert Goldin, who is a pathologist. He has said that when he is looking down his microscope, he can see the difference, you know, because there are differences between the different sorts of, or the different types of cholangiocarcinoma. So if something was biopsied, which was in the common bile duct, but it was down near the cystic duct, down near the gallbladder, would it not show that actually that was perhaps had moved its way down and was actually an intrahepatic cholangio? Or
so that's a really good point, and so that's a really good point, and I agree. As we learn more about the molecular pathogenesis of the different subtypes of cholangiocarcinoma, and hopefully biopsy more, and as John has pointed out in his talk, the molecular profiling of the mutations may be, in cases where you've got multifocal malignancy, we will in future, I think, be relying on the molecular profiling based on histology to determine where we think that cancer originated, and also to guide us on the relevant systemic therapy.
Yeah, because the more we're learning about the different types, the different anatomical types of cholangiocarcinoma, the differences in that are showing up on molecular profiling, you know, looking at the different types, you know, we get the different mutations in the different types. So this is going to become more and more important, isn't it? Because different treatments, the same treatment does not work for each different type, as we've seen with the, you know, one size does not fit all.
I mean, taking that argument even further, actually, you in a couple of years' time or a few years' time, you know, who cares what the coding is? All you need to know is the molecular subtype in order to treat it.
Yeah, but in the meantime, John, we need people to know. See, you know, without robust coding, we are not seeing the true number of people. We are not seeing how this is increasing year on year. We're not seeing the numbers of younger people, so we don't have the cold hard data. Well, actually, that's not quite right, because we are getting data now from AMMF's data work, but of course that's only in England. But data is still essential to actually to change policy and to improve situations. But you're quite right. I mean, if we could get really good, clear diagnosis, and then we know how we can treat, that's no problem then, is it?
Yeah, also it's important to point out that not everything is a mutational profile. I mean, with the targeted therapies, we don't cure the patient so far. So we are prolonging a little bit the life expectancy. So yeah, we need to consider almost other aspects in order to find, common and hopefully good treatments for most of the cases. No, and I think it's important to highlight that cholangiocytes along the biliary tree are different. So cholangiocytes in the liver are different than cholangiocytes in the distal part of the biliary tree. They originate from different embryological tissues. Also, they have different markers, different biology, and they are connected to different cell types. No, in the liver, obviously, the microenvironment is not the same that in the distal biliary tree. So, in principle and by definition, cholangiocarcinoma tumors arising in the liver are different than cholangiocarcinomas arising in the distal part of the biliary tree. No,
Mm.
so cholangiocarcinoma tumors should be definitely coded differently. This new coding is of tremendous help, but hopefully in the future we will provide additional codings, no, related to the biology and of the tumor. No, so we are in the way. This is the first part and the starting point. So yeah, looking forward for the use.
Always looking forward.
Yeah.
I think Shahid had a comment there.
Yeah, on that note, this is the third of our webinars, and I'm very grateful to everyone who's all the panelists and the organisers, and especially for everyone who's turned up around the world. I want to end on a positive note, and I am positive. I am optimistic, and the reason I'm optimistic is that I gave a talk last week at London's Royal Society of Medicine, and it was an update on hepatocellular cancer, and I was going through all the updates, and I sort of reflected on my own experience. When I became a consultant and senior lecturer in London in 2007, there was no real standard treatment for HCC. There was nothing on the horizon. And then a year later, the SHARP trial came out, and then we had sorafenib. And in the time I've been running, I set up an HCC clinic with my colleagues Rohini Sharma and Mr. Pai. And in that time, in the last 7-8 years, we've gone from nothing really proven to standard treatment with sorafenib, a second agent, nivantinib, a third agent, atezo combination, atezo-bev with a VEGF and a PD-L1 inhibitor. 2 options for second-line agents, regorafenib and cabozantinib. We didn't have CERT, we now have CERT. We didn't have IRE, we now have IRE. We were using radiofrequency ablation, we're now using microwave ablation. So all these things have happened in HCC in the last few years. And cholangio, there was again nothing. There was no standard treatment until the GEMSIS, so the work done by John and Juan and Harpreet Wasan and colleagues, the ABC trials, and now we're doing molecular profiling. Now we've got pemigatinib. So I do feel that yes, it is a bit slow, but I am quite optimistic when I think of how many new treatments that we have at our disposal in HCC in the last few years. I'm optimistic.
Also, one of the reasons why some trials failed was because of the number of patients included, and also on the lack of potential sub-analysis in clinical trials, potentially according to the location. That's an important thing that maybe you, John, want to comment, because I think this is something of benefit, this new coding for the for the design of clinical trials for future sub-analysis.
So this is it comes to the core of what Helen's been going on for years and years and years and years. Actually, when you get the numbers, when you do the studies, actually, the numbers are there to do proper clinical trials. All the trials before ABC2 were, without exception, less than 50 patients. I think the biggest one was 55. And everybody thought, oh, we can never do this, oh, there aren't enough patients in the world to do this. Actually, when you added up all the studies, there were thousands of patients around, and all you needed to do was to be bold and actually bite the bullet and do the study. And I think subsequent to this now, pharma are doing many hundred patients studies globally. Really very rapidly. So I think it's the Helen thing. We need to know the numbers, and it's believing in what you want to do. You have to go and do it. And I completely agree with Shahid. Cholangio probably lags behind HCC by a few years, but it's catching up fast.
We just had a last-minute question in there whilst we were discussing, and that was what changes coders can expect after implementing ICD-11 in insurance globally. I don't know if any of you have had any experience working with insurers and ICD coding. I expect we haven't got that experience in the panel, so that might be one that we need to take away. Okay, well, we've reached our time. We've now come to the end of our webinar series, and I'd like to thank the panel for today and for the previous webinars. Wishing you a fantastic day ahead, evening, wherever you are. And again, thanking the panel for all of their great work in this webinar series.